My name is Aki Kawasaki. I'm from Lausanne, Switzerland. And I'd like to thank the organizers for asking me to participate in this meeting. I have to say that the format of this meeting is really lovely. It invites discussion, it encourages questions from everybody, and there are many, many cases that we can discuss. So I think that this is the very strong point of this meeting, because through these cases and interaction, we can all learn something. Now, I've been asked to discuss toxic neuro-ophthalmology. Toxicity can be poisons, it can be heavy metals, it can be an excess of anything. But for this talk specifically, I'm only going to look at toxicity as a side effect of commonly used medications. The importance being that we can reverse these neuro-ophthalmic signs and symptoms if we recognize the drug and remove it. So I'm going to do this in a case-based format. Next slide, please. Perfect, thank you. Right. So this is a case, this is actually not my case. It resembles a person I saw many, many, many years ago, and I don't have the nice documentation, but this case so resembles mine that I have given you the reference for it down here. But let's discuss him. He's a 65-year-old black man with progressive visual loss in both eyes for 3 months. And at this point, he's having difficulty navigating his home. His vision is so low. And he says colors are washed out. No pain. He has no headaches. Ocular history, he's a glaucoma suspect. Now, his medical history is important. He was diagnosed with HIV 4 years ago. 1 year ago, he had a lung infection with Mycobacterium avium, a cousin of tuberculosis. But through all of this, he continues to smoke his half pack per day, every day. So his medications are all aimed at the HIV and all his infections. So he's taking highly active retrovirus therapy. He's taking ethambutol for the mycobacterium. He takes linezolid. He takes clarithromycin for different skin infections. And he takes various vitamin supplements and coenzyme Q.
What's linezolid?
Linezolid is Zyvox. It's antibacterial, 4 gram positive. So let me see if I can do this yet. So as we said, he has poor acuity in both eyes, about count fingers. He has poor color vision in both eyes. He has poor pupil responses in both eyes, and his visual fields, I don't have a copy, shows bilateral, temporally dominant cecocentral scotoma in both eyes. I show you his fundus. You can see the excavation. Maybe there's a little temporal pallor, maybe, and the rest of his examination is unremarkable. Okay? So, at this point, I want us to just step back, okay? Remove ourselves from this patient and look at the global picture. The global picture is bilateral, painless, progressive visual loss. That's the history. The examination is bilateral loss of acuity, symmetric. Bilateral central scotomas, symmetric. Bilateral dyschromatopsia. Bilateral temporal pallor, or probably atrophy. That picture, that global picture, should immediately evoke for you toxic optic neuropathy, metabolic deficiency optic neuropathy, or hereditary optic neuropathy, kind of your top 3, okay? Of course it can be something else. Of course it could be compressive. Of course it can be inflammation, infection, okay? But I just want you to recognize right away this picture, and it should make you think toxic metabolic hereditary, okay? So Could this be labor, hereditary optic neuropathy? Sure. It's subacute, it's progressive, it's central. Possibly. A little old, but we've seen that. Dominant optic atrophy, this is a little fast. It's, again, a little old. Could this be a metabolic deficiency? Sure. Okay. Could this be toxicity, like from cobalt, heavy metal, or medications? It can be, but we have to know which medications might do this. And then, as we said, it can be inflammatory, infectious, neoplastic, neuromyelitis. It can be a whole host of other things. Okay, but I want to concentrate on our top 3. So what we didn't yet discuss are what medications. What medications cause bilateral optic neuropathy, progressive, without disc edema. Okay, and it's kind of a short list. And ethambutol is the prototype. Okay, ethambutol is the prototypical toxic optic neuropathy. We use it for mycobacterial infections, and it is prototypical because it is dose dependent. So it has been identified that 15 milligram per kilo per day is associated with a very, very, very low risk, considered the threshold. Okay? As soon as you go above 15 milligram per kilo per day, that risk rises. So if you're over 35 milligram per kilo per day, your risk is almost 50% toxicity. Okay? Like most toxicity, it takes a few months to develop, but there are case reports of patients who develop toxicity in a matter of days from ethambutol. And the mechanism is mitochondrial dysfunction. So that's why it can look so much like Leber's, right? Which is a metabolic defect related to mitochondrial DNA. Okay, so let's again, the big picture is bilateral painless progressive visual loss, bilateral central secocentral scotoma, bilateral symmetric dyschromatopsia. We said pallor of the disc followed by optic atrophy. It will only get worse as long as they're on the drug. The good news is most of the time, if you stop the drug, it's reversible. So let's now go back to our patient. Okay, we can't assume this is ethambutol toxicity. We must do the workup. So here is his OCT. You can see some asymmetry in the nerve fiber layer, but he's not yet that atrophic. The MRI showed no compressive lesions. He has no metabolic deficiency. His labs show no granulomatous infectious infiltrative disease. His Leber test is negative. And we did the NMO antibody, which is negative. So at this point, we feel like probably toxicity. So we don't want to give him steroids. We just want to remove the toxic agent. How much ethambutol does he take? Well, calculated for his weight, he's taking 18 milligram per kilo per day. So it's just slightly above the recommended threshold. So we felt fairly comfortable that if we stopped the drug, he should get better. So we stopped the drug, and he got worse. So we're not happy. So now what do we do? Okay, maybe this is one of those rare permanent toxicities, but doesn't feel so good. Should we do more tests? Should we start steroids? Any ideas? Well, again, this global picture is so compelling for toxic, metabolic, or hereditary. I would say, look again. Okay, let's look again at that list of medications that can cause bilateral optic neuropathy without disc edema. I've highlighted some of the antibacterials, and as pointed out right away, linezolid is on that list. So, linezolid-related optic neuropathy looks exactly like ethambutol optic neuropathy, exactly. Okay, it is also dose-dependent, it is also related to duration, and it is also related to mitochondrial dysfunction. Linezolid being used for gram-positive infections, so osteomyelitis or chronic skin infections. These are uses of linezolid. So now we stop the linezolid also, and in 4 months after all, he's very happy. His vision is 80%, his color vision has returned, his world is bright again, and his pupils and visual fields, as you can see, have improved. So this is a case, in fact, of a combined toxicity from 2 drugs known to cause dose-dependent optic neuropathy. Now here's the big question. What about the antiretrovirus therapy? Okay. The group called the nucleoside reverse transcriptase inhibitors, of which zidovudine is the classic, AZT, okay, they disrupt mitochondrial DNA. Okay, so we know these drugs cause mitochondrial myopathy. We know they cause peripheral neuropathy. We're not sure they cause optic neuropathy, but they are dangerous because they accelerate or they potentiate optic nerve damage. So it means if your patient taking ethambutol is taking the correct dose of 15 milligram per kilo per day, but you add the heart therapy, then that 15 suddenly may feel like to the body like 20 or 25. So it's very important to recognize that these antiretrovirus therapies potentiate other toxicities, other optic neuropathies. The other interesting thing is it precipitates labor. So the person who has the mutation but doesn't know it, okay, and is doing fine, starts the antiretrovirus therapy and suddenly the labor becomes manifest. Okay? All right, let's now move on. If you type on the internet, okay, and you go looking for drugs that cause optic nerve damage, okay, so I did this. The first 3 that come up are ethambutol, linezolid, and isoniazid, okay? But what also comes up is phosphodiesterase 5 inhibitors, that's the group of erectile dysfunction drugs, and also comes up amiodarone, okay? And my point about these is that, oops, I'm too fast. Sorry. Okay, I'm doing badly. Can you back up, please? Yes, thank you. These 2, the phosphodiesterase 5 inhibitors and amiodarone, they're different because they cause discedema. Okay, so they don't look like ethambutol toxic optic neuropathy. So now let's look at a case. This is a 68-year-old retired professor who had visual blur fairly acutely in the right eye 2 weeks ago. He's diabetic, has ulcers, coronary artery disease, ventricular tachycardia. So his medications are insulin, an acid blocker, warfarin, and amiodarone. His visual acuity in the affected eye is not so bad. It's 20/25. He misses a few color plates, so mild dyschromatopsia may be a relative afferent pupillary defect. You can see the corneal verticillata. This is from amiodarone, but it is not a sign of toxicity. It just means you're taking amiodarone, and his intraocular pressures are fine. His visual field suggests this defect, and on the Goldman, you can see he has a definite paracentral scotoma. But in the other eye, he has this scotoma, a kind of an arciform scotoma, which is not bothering his acuity. So we have maybe bilateral disease. So at this point, this is a person who has vascular risk factors, acute visual loss in one eye, disc swelling in the bad eye, a crowded disc on the other side, a unilateral, maybe bilateral scotoma. What do you think this is? Well, to me it sounds like non-arteritic anterior ischemic optic neuropathy. Okay? What would be my differential? Well, I could think about diabetic papillopathy, inflammatory, compressive. But the big question is this amiodarone? And how would I know? Okay? Well, we're not even sure that there's a definite amiodarone toxic optic neuropathy. The recent data from Taiwan is that in over 6,000 patients taking amiodarone, compared to 25,000 age-matched controls, optic nerve disease develops in 0.3% of amiodarone patients, but optic nerve disease develops in 0.1% of the control group. Yes, there's a higher risk if you're male and you've been taking amiodarone for a long time, but it has nothing to do with the dose of amiodarone. So dose doesn't matter. So finally, it's said that amiodarone is associated with a risk of optic neuropathy, but again, we're not sure that it directly causes a toxic optic neuropathy. Okay? So, does it look like ethambutol optic neuropathy? No, not at all. First of all, we already said amiodarone optic neuropathy, if it's causing optic disease, is causing disc edema. But from there, it's very vague. Amiodarone visual loss can be bilateral or unilateral, acute or progressive and insidious, reversible or permanent. It's just very vague, very ill-defined. We've looked at our own series of 22 patients taking amiodarone, and what fell out of our 22 patients is that those that pretty much look like amiodarone optic neuropathy, they look different. They have bilateral disc edema, and the disc edema doesn't go away. It's there for 2, 3, 6 months. They have other signs of amiodarone toxicity, like a tremor or ataxia. And of course, we find no other cause of optic neuropathy. So with these criterion, we have a clinical category that we call definite amiodarone optic neuropathy. And then there's a category where the patient is taking amiodarone, but they have acute visual loss, unilateral disc edema, crowded disc on the other side, and it just looks like typical non-arteritic NAION, so I think we should just call it that, okay? And then you have the gray group. They have unilateral disc edema, but maybe not acute visual loss. Or they have unilateral disc edema, but a non-crowded disc in the other eye. So it's a little harder to call this garden variety typical non-arteritic AION. So this is probable. So now let's go back to our patient, okay? If you remember. I wanted to call him, and I did. I called him non-arteritic anterior ischemic optic neuropathy. So I did just, kind of the minimal workup, making sure it's not giant cell, not other grossly inflammatory conditions. And somebody, for some reason, I don't usually get an angiography for non-arteritic anterior ischemic optic neuropathy, but lucky for him, somebody did it. And the big surprise is that both optic nerves showed early leakage. This doesn't match the picture for clinical non-arteritic NAION. So now we have to think larger. So we did temporal artery biopsy, we did MRI, we did lumbar puncture, all of it negative, negative, negative. Okay, and remember he had a bilateral visual field defect. So now I have to change. So I said, well, diabetic papillopathy can cause bilateral disc edema. Okay, that's okay, so maybe it's that. Or maybe this is amiodarone. So now I'm thinking maybe amiodarone. We observed him, things were getting worse. We discussed with the cardiologist who said, okay, you can stop the amiodarone, so we did. And 1 month later, everything stabilized. 4 months later, you see bilateral optic atrophy. So he truly had bilateral disease. Okay, so we felt, got it. Then I didn't feel so good because 6 months later, I got a letter from the cardiologist. The patient dropped dead in his house from a cardiac arrhythmia, which was probably because we stopped the amiodarone. Okay, so what happened to our other patients? Did they all die? No. For 17 patients, where we stopped the amiodarone, I'm happy to say that 15 were able to be stabilized with other medications. One did have to go back on amiodarone, but of 17 patients who stopped amiodarone, 2 died within 1 year of stopping the drug. And I just presented to you one. This is a very high percentage rate. This is a high mortality. So my message is this. In the patient who develops optic nerve damage or optic disc edema and taking amiodarone, first of all, just make sure this isn't your standard non-arthritic AION. This is the group who's going to get it, okay? And if it's NAION, stop there. Don't even think amiodarone. If you rule out all other causes and you're really thinking amiodarone, okay, you must discuss with the treating doctor. You must be clear that this is not dose dependent, okay? And you must be clear that all we have is correlative data saying there's an association, but not direct causation. Because as you can see, the consequence of stopping a powerful antiarrhythmic like amiodarone is also very serious. So I do believe amiodarone optic neuropathy exists, personally. I do believe it's fairly rare, okay, but I am humbled by my experience with calling it, stopping the drug, and having a very negative consequence. Okay, so I'm going to move on and stop talking about the optic nerve. We're going to, yeah. Yeah, so the alternatives to the antiarrhythmic is based on, is a cardiologist's choice. But for the 2 that died, they tried other medications in between, and apparently it wasn't effective, right? Okay, so I want you to listen to this story and tell me what is the symptom, okay? This is a 30-year-old woman who noted after images. So the first time she was getting her hair done and she was looking at a lamp, and then she looked over here and the lamp was still in her vision. And then when she went home, she notices that often what she's looking at stays in her vision for a few seconds, like a photographic negative, and then it fades away, okay? So that's her complaint. Oh, by the way, she also notices that when she's driving, car headlights leave like a line. So it's confusing to her because she sees lines all over the road that she's driving on. So first of all, what do we call this? Besides after image, yes. So this has a name, and it's called palinopsia. So the first thing I want you to do is recognize palinopsia. It comes in different forms. The first is, as we said, prolonged after image. It can be like a photographic negative, or it can come in different complementary colors. For some people, palinopsia is exactly the image that they saw. So for example, you come to an intersection and you look at the stop sign. But then you look at the other side and you still see the stop sign. And then you look across at the park and you still see the stop sign. Okay, this is identical image palinopsia. Other types of palinopsia is just one feature, some very striking features. So this woman was watching a movie with the famous detective Hercule Poirot and his big mustache, okay? And then the kid said, "Mom," so she looked at the kids, and the kids were wearing the mustache. Okay, this is palinopsia, okay? Or looking at a chessboard and then seeing the pattern everywhere that you look. This is palinopsia. And there's this very specific form called trailing, but it is palinopsia. It's just that the moving objects leave kind of like a stroboscopic ghost image, so that ends up leaving a line, which we call a trail. Okay, all these are forms of palinopsia. And my point is that palinopsia is commonly a side effect of prescription drugs. So once you know the symptom, you have to go after what drugs are they taking. Antidepressants, antipsychotics, the fertility drug clomiphene, and just recently one case of acetazolamide and topiramate have been reported. And the point of all this is that drug-related palinopsia is reversible. So if you recognize the symptom, find the drug, stop the drug, it goes away. Wonderful. Now, palinopsia is also a side effect of illegal drugs. Okay, it's a side effect of LSD, it's a side effect of PSP, psilocybin, even marijuana. Okay, the big difference is that the illegal or illicit drug-related palinopsia is often not reversible. Okay, so here's an example patient that I saw several years ago. It's a 27-year-old healthy woman who was referred for photophobia, but she wasn't complaining of photophobia. What she was saying is that when she drives at night, the lights leave these trails in her vision, so she can't see the other cars. So everything is just these lines, okay? Is she taking medications? No. Have you ever used recreational drugs? Oh, no. No. Well, okay, as we keep talking and you keep pushing, well, okay, at a summer music festival this year, somebody gave her a capsule full of hallucinogenic drugs because it would make her music experience grander. So yes, she had immediately hallucinations, halos, trailing, ghost images, but the next day she still had the trailing. And 8 years later, she still has the trailing. Irreversible. Okay, so do we evaluate patients with palinopsia? Yes, you still must make sure it's not other things. Mostly make sure it's not occipital lobe epilepsy or temporal lobe epilepsy. So we do visual fields, I do head MRI, I get a few blood tests, and I always refer the patient to neurology for EEG, okay? And then you might get VEP, ERG if you want to look at the retinal status, but I've never found anybody who has either a retinal or cortical problem. My big message is, especially for young persons with palinopsia, go back and keep insisting about even one-time use of recreational drugs. Now, I just want to, if I have just a minute, to deviate into an interesting historical aspect of this. First of all, LSD was first synthesized in all places, Switzerland, okay? And LSD, this hallucinogenic drug, comes from a chemical found in ergot, okay? What is ergot? Ergot is a fungus, and this fungus grows on the rye plant. But the ergot, the fungus, looks like the seeds. So what has happened is sometimes you bake bread with rye and it's full of ergot fungus and not the seeds, okay? So this causes ergotism. This is eating bread from contaminated rye. And the symptoms of ergotism or ergot poisoning is convulsions, major hallucinations, and then in severe cases, gangrene. Now, why is this interesting? Well, in the medieval times, children who were bewitched or taken by the devil, right? Well, they might have been just poisoned by ergot. Who poisoned them? Well, the witch. The witch cast a spell on these children. Who are the witches? They're women, because the women are the bakers, right? So this is an interesting book which looked at the correlation between locations of major witch hunts and witch trials in Europe, which correlated with high regions of high rye consumption and high use of rye in bread. So again, suspicious that they were just toxic. Okay, and I finish with this very short case, okay, mostly as an example of what else prescription drugs can do. This is a 45-year-old woman, and she does complain of photophobia, meaning lights, indoor lights, give her discomfort. She also says, interestingly, my eyes are not so dark anymore. She says, I normally have very, very dark brown eyes, and these are not so dark brown. No other ophthalmic history. She mentioned she had red eyes a few months ago. She had a sinusitis a few months ago, nothing serious. And now on examination, she has pupils that are just immobile. They don't react to light. They don't react to near. And on closer look, she has large areas truly of iris depigmentation without major transillumination defects. She has fine pigment keratotic precipitates, circulating pigment, pigment in the deposits, the pressure's still 20. You can put direct pilocarpine in, and the pupils don't react. So what is this? No, but close. It's a side effect. So this is my point, is this is now increasingly described with an antibiotic called moxifloxacin. It's a third or fourth generation fluoroquinolone. You know the earlier generation is ciprofloxacin. Moxifloxacin is a newer derivative. And it's called BADI, bilateral acute depigmentation of the iris. And so when we push the history, yes, for the sinusitis, she took an antibiotic. So now you have to be the detective. It's like, which antibiotic? And she says, I don't know. But in this case, you should call the family doctor and say, by the way, which antibiotic did she take? And it's moxifloxacin. Okay, so body is benign and it will be reversible, so she will get her eye color back. Her pupils should become reactive again. This should be distinguished from BAIT, bilateral acute iris transillumination, because here the patient can actually get a uveitis-like syndrome, and all the findings that I've just described are irreversible. So pupillary side effects or iris side effects due to antibiotics. So just another red flag to keep in mind. I think that's all I have. Yes, thank you very much for your attention.
And may I ask you, which is the relationship between palinopsia that you showed before and visual snow syndrome? If there is any relationship
Between palinopsia and
the visual snow syndrome?
Oh, visual snow. Ooh, okay.
Are different, same thing, similar?
I think visual snow is in the category of palinopsia, but it's not an after image. Does everybody know visual snow? No. Okay, so visual snow was described, I don't know, 15 years ago by Grant Liu, okay? And what it is, the patient sees perfectly fine, but superimposed on the vision are little pinpoints of light. Sometimes they look like snow, falling snow, or many patients describe like a television static. Okay, it's just slightly moving and it's slightly bright or white, but it doesn't block vision. They have their vision, but it's like somebody put a layer on top. This is visual snow, and we're hearing about it more and more, and I'm not sure why. It's currently in the category of palinopsia, but I'm not sure that they're the same because it's not an after image. It's not provoked by looking at something. It's there spontaneously. And I have not found any medication that works to improve visual snow. Do you have a different experience?
No.
Okay. Other neuro-ophthalmologists, different experience with visual snow? Okay, so sometimes it's associated with palinopsia. So if they have snow and palinopsia, then you want to go after the drug and do the workup. Okay. Right, so the question,
I was told that it is a kind of entoptic phenomena, so you become aware of something that it is inside you. So it's a kind of different process.
yeah, so both palinopsia and visual snow have been suggested to be entoptic phenomenon that the person becomes aware of. I think that might be true for some cases, but other cases are so distinctly different. It's hard to imagine that your world is suddenly pixelated and that's entoptic. It's like, what internal structure looks like that? Other patients do report that if they look at a clear blue sky or something, right, they can see the little snowflakes or maybe vessels, right? That, I think, is entoptic, but I think visual snow is different. Of course, the current hype is it's because we're all looking at a blue screen all the time. I don't know. So it's a mysterious, still mysterious phenomenon, but we are hearing more and more about snow. Other questions?
Yes, I have a question here.
Yes.
Thanks for the great presentation here. I wanted to ask, is there any role for the idebenone in toxic optic neuropathies or any other medication that you can use besides stopping the cause of the neuropathy?
So that's a great, so the question, of course, is can you use idebenone because of the mitochondrial dysfunction in labors? Could we transfer that by analogy to a toxic optic neuropathy? I don't see any problem in trying it with the ones known to cause mitochondrial dysfunction as their basis. So for example, the patient that I presented who had ethambutol and linezolid, if he didn't get better, it might be an idea to add the idebenone, but of course the effect would not be immediate, right? And then of course coenzyme Q and other type things might be suggested. For amiodarone toxic optic neuropathy, I must say I would not add idebenone. Your experience, your thoughts?
Well, I'm specifically asking this question because I'm going to present later a case.
Okay,
where
good.
We couldn't stop the medications or we couldn't correct the causing of the toxic neuropathy, and we tried idebenone.
Okay,
So
fabulous.
yeah.
Maybe a comment from our labor specialist? Yes.
Yes, the problem in the ethambutol toxic neuropathy is that the patient is hospitalized, so often it's too late. So we see the patient too late.
Yeah.
And this is the reason because we need a collaboration with cardiologists or other doctor who use this kind of problematic drugs. And because we see the patient too late. And sometimes ethambutol optic neuropathy is very severe. I have a question for you about visual snow, because we had noticed to treat patients with lamotrigine. You have experience with lamotrigine?
Lamotrigine, the anti-seizure medication?
Yes, to use in the case of visual snow.
Yes, so I haven't personally used lamotrigine, but I've used other anti-epileptic drugs for visual snow, and my personal experience is none of them work. But if you have favorable experience with lamotrigine, I'm ready to try.
No, I have 3 patients, and one patient had a good effect, other 2 patients, nothing.
Okay, so that's the most positive. So I hope you all heard that. Lamotrigine might be anecdotally something to try for visual snow. Dosage, low dose? Progressive increase, so starting low and going high. Again, you're not treating epilepsy, so you don't need to do all the screening and follow-up like we would do for anti-epilepsy treatment. When you use these drugs, we're using very low doses and going up very slowly. Yeah. One other comment about ethambutol. There are guidelines that if the person is a person at risk, so for example, taking antiretrovirus therapy or taking a second potentially optic nerve drug, the guidelines for ethambutol screening are much like Plaquenil and in fact stricter. They say once a month. So somebody at risk for ethambutol optic neuropathy should be screened once a month. That's a lot. But it speaks to what Piero was saying, is you have to catch them early if you think you're going to reverse the visual loss. Okay, well, thank you very much.